The diagnosis is pityriasis rosea. This one is really tough to make the final diagnosis like this, honestly. So I don't know how the text will text you this diagnosis. So this one also fall into the spongiolitic dermatitis chapter because when you see low power like this, you're just thinking just like normal skin because you do not see any dramatic changes here. And then one is a tricky thing when you see the slide during the examination. You can see this is a punch. This is not a superficial shave. If you see this is a punch, really highly suspicious of dermatitis because usually the dermatology will do punch to warn you to make diagnosis, the differential diagnosis of dermatitis. If they just give you a shape, it's highly suspicious for a maybe basal cell or maybe squamous cell, kind of this neoplastic lesion. So when you see a punch, you will think, oh, it could be just want to text us about dermatitis, but not always, but just most of the time you can use this trick to just know what diagnosis they want you to make. So and then go back to this slide, kind of more like normal skin. But when we zoom in, one thing should catch our eye. That is this perikeratosis. And then this is not confluence. Confluence, that means all the cornea layer, you will see this perikeratosis. This one just like subtle area. Maybe this one, maybe better. Yes. Just a little bit. Catch your eyes. And then we call this mount perikeratosis. I think just like something on top of a mountain. I don't know why they call this mount perikeratosis. I think when you see this small area of perikeratosis, you can thinking about pityriasis rosea of this diagnosis. And then what other feature we can see in this pityriasis rosea? Other than this mount perikeratosis, we can see a little bit spongiosis here, especially under this perikeratosis area. See, this is spongedom under this perikeratosis area. And then even under this area, you will see perivascular lymphocytic infiltrate. Then usually we will find extravasated red blood cell. This is all of this red thing is red blood cell. Usually you won't see eosinophil. If you see eosinophil in the normal cell, we will just kind of not thinking about pityriasis rosea. So just repeat one more time. Mounted perikeratosis, spongiosis, extravasated red blood cell. With this feature, you can thinking about this pityriasis rosea. I think it's really tough because these changes, I mean, really subtle. Sometimes you just do not pay attention. But I think the first thing you need to remember just this mounted perikeratosis, because I think for this whole chapter, I don't even thinking any other diagnosis. You can just have this mount. Oh, maybe have one. When we have that, I will also tell you which one. We should have one. I put one case of that diagnosis. Any question about this one? Because I opened the slide ahead, so maybe it will take time for it to reload the slide. Okay. And the next case, we have the diagnosis of psoriasis. Actually, psoriasis, we usually, in the regular sign-out, we won't usually just put the diagnosis like psoriasis there. We always use the term psoriasiform dermatitis because it's not really specific unless we see the clinical picture is really classic for psoriasis. And another clinical problem is that if the dermatology, even the family doctor, thinking about psoriasis, they usually do not biopsy that lesion. So we in the clinic we usually not see really classic psoriasis, but in the text I think this is classic psoriasis. So to make the diagnosis of psoriasis, you need several features. First is this is a conventional like regular psoriasis. So we can see this parakeratosis confluence. That means most of the lesion we can see this parakeratosis here. Then we have under this parakeratosis you can see the granular cell layer diminish. That means usually we will see a little bit purplish in this granular layer, but in psoriasis under the parakeratosis you could not see really clear purplish area. That is the hypogranulosis. Then we usually do not see spongiortic dermatitis, but if the patient feel kind of itching, they scratch, you will see that like here, just a little bit. But the spongiortic would not be your main thinking in this psoriasis. Then we have this regular elongation of the RED. Regular, that means we have the same level of all the RED ridge like here. That is regular. Regular for the psoriasis. So we have three pattern: confluence, parakeratosis, and then when we zoom in, we usually can see neutrophil. Somewhat like here, this is dark nucleus to be neutrophil. We can see this binucleated, that is neutrophil. So neutrophil in the stratum cornea layer is the characteristic of psoriasis. Then you can see this granular cell layer kind of diminish under the parakeratosis. Then we can see these dilated vessel in this dermal papillae. So this make you think of in the clinic when the dermatologist try to scratch the plaque of this psoriatic lesion, you will easy to see some blood, because when you take something out, it's really easy to break this vessel. So all of these feature is psoriasis. So I think the most important thing is the parakeratosis and the neutrophil inside the para. And then low power with regular psoriasis form. That is the RED in the same level here. So this is psoriasis. I think I have different, okay. This is called the Gauthey psoriasis. Gauthey psoriasis kind of mimic the previous one. That is the pityriasis rosea. I think this one is not that good. Usually they also have this mounted parakeratosis here. Let's see whether we can see. Yes, for this one we also have a little bit mounted keratosis. You can see the nucleus still in the stratum corneum here. And then we can see some neutrophil. This is bilobated neutrophil in the stratum corneum. And then you ask me why we do not see any psoriasis irregular elongation of the RED. That is one of the tricky thing for this diagnosis, Gauthey psoriasis. You do not have perfectly elongation of the RED. You can see here, you can see a little bit elongation, but the pattern is not really like the psoriasis. I don't think it has, they will give you this one to make the diagnosis, but just would like to draw your attention. Not only the pityriasis rosea can have this mounted parakeratosis. Other dermatitis will also have this. So we also have parakeratosis, neutrophil, a little bit elongation of the RED, and also this dilated vessel just in the dermal papillae. Also another characteristic feature. Then you can see in Gauthey psoriasis, you still can see this thickened granular cell layer, but under the parakeratosis area, you can still see maybe a little bit diminished thinning of this granular cell layer. But go back to the previous one. When you see conventional psoriasis, when you see this the granular cell layer should be really thin. You could not see this thicken of the purplish granular cell layer. Okay, this is another mimicker. This lesion called a clear cell acanthoma. When you see this low power, you may also think of, oh, we have this regular elongation of the VD ridge. So you may think about psoriasis, but something you do not have, just that parakeratosis with the eosinophil. But I would like to tell you this lesion, you also can find eosinophil in the top and even in the epidermis. But one thing can take you apart of the psoriasis diagnosis and then make this clear cell acanthoma diagnosis is in low power. You can see we have really demarcated clear cell area. This is the normal epidermis, clear cell area and then normal epidermis. So really well demarcated. In the psoriasis, you just see everything just like this color. You won't see this clear cell changes. Even in this low power kind of a mimic of psoriasis. So when you see this clear changes, like well demarcated, clear changes of these two color, you do not think about psoriasis, think about clear cell acanthoma. And then go to high power, you can see this really clear cytoplasm. Then you will find some neutrophil in the epidermis like this one, and also maybe a little bit in the stratum corneum. So I think this is a really good mimicker for the psoriasis. But this is called a clear cell acanthoma. Let me go to next case. Okay, this case diagnosis is lichen planus. Lichen planus for the clinic, that is multiple lesion, usually in the ribs or maybe in the extended surface of the extremity. Then lichen planus is the classic changes in the lichenoid interface dermatitis chapter. So I think some people are always kind of confused about lichenoid changes. When they see tons of lymphocytes in the dermis, they will say this is lichenoid changes. But truly, lichenoid interface changes, that means we not only find tons of lymphocytes in the dermis, but another thing we need to see, you can see in this DEJ junction, you just could not draw a really clear line between the epidermis and the dermis. When you see these changes, this is true lichenoid interface changes. If you can see really clear between the lymphocyte and the epidermis, that is not true lichenoid changes. So like this case, lichen planus, this is true lichenoid interface changes because you just could not draw a clear line between the epidermis and the dermis. Of course, in low power, we can see this really dark area that should be lymphocytes. And then let's zoom in to see some other feature for lichen planus. So one thing you need to bear in mind, the BLK, that is the benign lichenoid keratosis, and lichen planus, usually in the microscope, they are identical. You just could not tell them apart usually. But one thing you can tell them apart, that is lichen planus. You can think like a strict parents. They have really strict diagnosis criteria. The first one is you could not see parakeratosis for a lichen planus. You can just see this wave basket of parakeratosis or maybe hyperkeratosis. You could not see any nuclei in the stratum corneum. If you see any parakeratosis nucleus in the stratum corneum, you could not make the diagnosis of a lichen planus. You And then you can see this thicken of the granular cell layer. I think this one is not really good. I have another good example to show you this feature. That is the pyramid shape of hypergranulosis. That means this purplish cell just forming kind of like a triangle shape, something like this in the lichen planus, but this one is not really good. Then let's zoom in to see other feature. These cells lose the nucleus. Actually, these are the keratinocytes, but this cell we call the keratinocytes is dying. Another term is this keratotic keratinocytes. If you want a fancy term, that is Shiva body in the epidermis. If you find something like the same thing happen in the dermis, maybe this cell or maybe other cell also lose their nucleus. That is the colloid body for this lesion. Then you can see these two lichenoid changes. So the lymphocyte just attack the DEJ junction to just make kind of blurry of this DEJ. So again, make this diagnosis. You also could not find any single eosinophil in the dermis. If you see eosinophil in the dermis, usually touch you away from the lichen planus. I think this is just red blood cell, not eosinophil. So then you can see this dying keratinocytes. This is colloid body, this is VAR body, tons of them. So and then you can make the diagnosis of lichen planus. So just quick pickup. Low power, see this lichenoid intervening changes, really blurry DEJ junction. Then just wave basket of keratosis, and then hypergranulosis. Then you can see dying keratinocytes in the epidermis, and then no eosinophil in the dermis. Then you can make the diagnosis of lichen planus. Here I want to show you another lichen planus case. So low power, we also know that this is true lichenoid intervening changes, because here you cannot see a really clear DEJ junction here with this band, really heavy infiltrated lymphocytes, and then hyperkeratosis here. This one just show you really good this pyramid triangle shape hyperkeratosis here. And then because the lymphocyte try to attack the DEJ junction, so sometimes you will see this empty space, kind of DEJ junction of 4 parts, could not kind of confuse about the split disorder, just like pemphigoid or maybe pemphigus or other blister lesion, because this normally the lymphocyte will attack the DEJ junction, so they will create this space. Oh, and then one thing I forgot to mention, true lichenoid, this lichen planus, you see this jigsaw. That means this DEJ function, DEJ, you just see this jigsaw changes because the lymphocyte just like attack the DEJ. Because usually our melanin just stay in this basal cell layer. So if the lymphocyte try to attack this DEJ junction, this melanin pigment will drop out. That means this pigment will go to the dermis, something like this. Because of the lymphocyte attack the melanocytes, maybe the keratinocytes, so the pigment will just go down. So this one is another one for lichen planus. Then I want to show you benign lichenoid keratosis. As I mentioned, it could be identical to the lichen planus, but for the clinic, the dermatology will tell you just a single lesion, not multiple lesion. Then you will think about just benign lichenoid keratosis, not lichen planus. But actually, the changes is really similar. We also can see these really lichenoid changes. You can see this DEJ is kind of blurry. This one is really good. You just could not tell the epidermis and the dermis. You can see these jigsaw changes of the DEJ because the lymphocyte just attack the DEJ junction. Then we can see this pyramid hypergranulosis, something like this. And then a lot of dying keratinocytes. You can see it everywhere. Oh, and then for the test purpose, if you do immunoinfluorescence for lichen planus, you will have some, I think, IgG and C3 deposition in these dying keratinocytes in the dermis. So that's a characteristic feature for the immunoinfluorescence for the lichen planus. So you can see benign lichenoid keratosis just look like identical to the lichen planus. But sometimes you may find eosinophil or maybe keratosis to make you more thinking about benign lichenoid keratosis. But this one we just could not see. Another case for BLK, benign lichenoid keratosis. We also can see lichenoid band here. And then the DEJ junction, because attacked by the lymphocytes, so they kind of fall apart. And then we can see some pigment drop out here. And then pyramid hypergranulosis. And then with a lot of dying keratinocytes. So this one is another case of BLK. And then for the differential diagnosis, I would like to put this one because I think for the text purpose, this one is really easy to make diagnosis. This one, the diagnosis is lichen nitidus. Actually, you can think about just like this is a lichen planus, but really focal lichen planus. We have this colorate, the epidermis just hugging this kind of ball-shaped lymphocytic infiltrate like a lichen planus or maybe BLKs. And then when you zoom in, you may also see histiocytes forming kind of granuloma with the lymphocyte. You can see clearly this is histiocytes mixed with the lymphocytes. But we can see clear this lichenoid interface changes. So this one is lichen nitidus. I think for test it's really fair to give you this because this one, really easy to make the diagnosis. You can see also find some parakeratosis here. So when you see parakeratosis, just do not make the diagnosis of a lichen planus. It should be something else. So hopefully you can recognize this lichen nitidus, just like small focal area of lichen planus or BLK. Any other questions so far? I know this dermatitis kind of tough. Just this small little thing. And then this one, I think in our GYN lecture, someone already covered this. Everybody should be really familiar with this one. This is lichen sclerosus. In the vulva, usually really itching lesion. So we usually make this diagnosis in several seconds usually because even low power you can tell. We have a mnemonic like pink, white, and blue because the pink is the epidermis and the stratum corneum, the whitish, that is the edema of the superficial and papillary dermis or homogeneous collagen. So this is a whitish, and then the blue, that's the lymphocyte. Pink, white, blue, make the diagnosis of lichen sclerosus. But usually we still need to zoom in because one of the mimicker of this lesion that is the chronic radiation dermatitis. You can see something, you can see chronic radiation dermatitis really identical to the lichen sclerosus. You can also see pink, white, blue, but when you zoom in, if this is true chronic radiation dermatitis, you will see really bizarre looking fibroblasts. But in this lichen sclerosus, we just can see really normal fibroblasts. We could not see this stellate shades and really big polymorphic fibroblasts. If you see that kind of fibroblasts, you need to suspicious of chronic radiation dermatitis. And also another feature in chronic radiation dermatitis, you can see a lot of dilated blood vessel, not just these three. These have a lot dilated blood vessel in chronic radiation dermatitis. Of course, when we see lichen sclerosus, especially in the vulva, we need to screen whether any neoplasm, especially our D-vein, HCL, something like this, squamous cell carcinoma in the epidermis. So this thing we need to really focus, do not miss any neoplasm when you make the diagnosis of lichen sclerosus. Then I don't think this is a really great mimicker, but still in the book, that is Morphea. Morphea is localized scleroderma. If you want to make the diagnosis of Morphea in the low power, you can see this deep punch biopsy. Usually the punch biopsy, you could not see this rigid edge. We call this square punch. That means the whole punch just like a square. Usually you won't see a square punch. If you see square punch, that means something going on in the dermis, either like this diagnosis Morphea. That means the sclerotic collagen just make this square punch. Another square punch, that means a lot of cell infiltrates in the dermis, maybe just like dermatofibroma, or maybe metastatic breast carcinoma. A lot of cell just infiltrates in the dermis, so you may make another square punch. But for focus on this slide, Morphea, that means everything just sclerotic. We lose the fibroblasts between this collagen bundle in the dermis. That means we do not see a lot of nucleus here. Then we also lose the annexal structure. That means sometimes we may still see some vessel, but we do not have the acrine gland. We do not find any hair follicle. If we find acrine gland, it usually just deep. They do not have here. Even we can find some acrine gland here, they will lose their fat, because we know acrine gland, we call acrine coil, they always with some fat around the acrine gland. And then we zoom in, we just could not see a lot of fibroblasts. But you need to pay attention. Sometimes in the earlier Morphea, you will see a lot of inflammation, including lymphocytes or plasma cell. So you need to see some high power to find, oh, this is true just lymphocytes, not a lot of fibroblasts. So this is Morphea. You can see we do not see any hair follicle. We just see maybe this is a vessel, but do not see acrine gland, maybe here, but just deep, just not in the superficial. But as we know in the lichen sclerosus, we need to see kind of this sclerotic collagen up in the superficial dermis, not go deep down. And then we have tons of lymphocyte inflammation in the deeper area. Okay.